Started with our keynote speaker. So I am going to start the introduction while people find their seats. So I am very honored to introduce our keynote speaker, Dr. Sonika Agarwal. Dr. Agarwal is an associate professor of neurology and pediatrics and clinical director of the Fetal Neonatal Neuroscience at Children's Hospital of Philadelphia, and section head of neonatal neurology at CHOP. And she went to medical school in India and trained in maternal fetal medicine and OB-GYN and worked as faculty at preeminent centers in India prior to training in child neurology at Baylor Texas Children's. She has a special interest in education and mentoring and has been awarded several education awards, including the 2020 CHOP Neurology Faculty Teaching Award, the 2020 AAN A.B. Baker Teacher Recognition Award, the 2018 Jefferson Neurology Faculty Teaching Award, and many others. She is also a recipient of the 2016 CNS Outstanding Junior Member Award for her work on fetal neurology registry at Texas Children's. She serves on the board of directors at the Child Neurology Foundation, and she is the director of the Resident Fellow Board and associate editor of the Fetal Neonatal Neurology section of the Journal of Child Neurology. She is an editorial board member of the Pediatric Neurology, the journal, and is on the steering committee of the Global Pregnancy Collaborative. Her collaborative leadership work in the American Academy of Neurology 2021 Transforming Leadership Program led to the development of the Fetal Neurology Consortium and subsequently the Fetal Neurology Special Interest Group. She serves on national committees at the CNS, the AAN, and the ABPN. Dr. Agarwal has been elected the vice chair of the Child Neurology section and a fellow of the American Academy of Neurology. Her clinical research interests include outcome studies and understanding parental perspectives in fetal neonatal neurology. And she is a dear mentor of mine who encouraged me into the field of neonatal neurology as my interest during residency. So very happy. Thank you so much for joining us, Dr. Agarwal.
Thank you so much, Margaret, for this lovely introduction. And Dr. Puri and his team for inviting me for this, am I audible enough? Or okay. For this talk. It's been a lovely experience meeting everyone, talking to the residents and the pediatric residents this morning. So I'm going to give you an overview of fetal neurology and what the current practice looks like and what the future directions are. So I'll review the current practice of fetal neurology. I'll discuss the challenges in the prenatal counseling of these disorders, and also discuss some of the collaborative work we have done through the consortium, and that can help us advance the education in this field. So this is a slide I like to show in all fetal neonatal presentations, where if you look at the green on this graph here, there's 40% of the global burden of neurological disease is due to fetal neonatal disorders. Primarily, it's identified as neonatal encephalopathy and prematurity-related conditions. And as the period advances through adulthood, the burden of neurological disease in comparison to other medical disorders is only 10%. But look at the 0 to 28-day period, how high the burden is and what can be done in that period to change the care for these critically ill infants that impacts their disability across the lifespan. Now, the contribution from fetal disorders is really less known, and the field has really evolved in the last 2 decades or so. But these disorders together can cause about 7% of the mortality, and 50% of the disability are just expected life years, the disability across the lifespan through these disorders is preventable. So if you look at a brief history of fetal neurology, it initially started with just ultrasound and karyotype testing, testing for congenital infections. But as the field evolved, real-time ultrasound came, and then late in the 80s, there was the evolution of this MRI, where the Meridian cohort, in UK, they looked at the utility of fetal imaging, which was found to be safe and in pregnancy, and this was as an additional test in combination with the prenatal ultrasound once a brain anomaly is identified. This is the myelomeningocele in utero repairs, and then if you look at in the last few years, there's been in utero enzyme replacement therapies, there's in utero repair, embolization of the vein of Galen, the vascular malformations in the brain, gene therapy trials in animals, and some experimental therapies. And so really the field has evolved. Exome and genome, where they were initially done only when after a baby was born. Now in the field of fetal neurology, we are seeing increasing use of this in the prenatal period. So fetal neurology is a complex field, and it's like changing and evolving very rapidly. So this is the earlier studies on the ultrasound and MRI utility that I mentioned, and the utility of whole exome. Really, initially, after a first anatomy scan, the patient gets referred if there's an anomaly for fetal MRI and for a consultation. CNS disorders are the top reason for fetal MRI and for consultations in the prenatal period for birth defects. So the contribution from brain disorders is really high. After they get the imaging, they meet with the OB and MFM, the maternal fetal medicine specialist, and we get consulted when there is a problem with the brain. Infectious testing, neurogenetic testing, there's gene panels, there's whole genome. Infectious testing, more for the congenital infections. You all may have heard cytomegalovirus, toxoplasma, parvovirus, all these conditions which are associated with brain conditions. And then rapid testing in the prenatal period, more informed counseling, connecting with the specialist throughout the pregnancy for fetal health. And then once the baby is born, care in the newborn period with resources for early intervention as they get ready for home. So fetal brain MRI, and Dr. Means' talk was really good, and she showed some really good pictures, but the fetal, one big limitation is the fetal brain MRI, the brain is still forming. So if you look at a fetal brain MRI at 21 weeks, it's smooth, right? But if that's a term baby, that would be called lissencephaly, but not at 20 weeks. All brains are smooth at 20 weeks. And as you go further, you see more of the folding appear till about 40 weeks of pregnancy. And similarly for the cerebellar development, you see how rapidly the cerebellum grows. So the brain is very dynamically maturing and growing over in the fetal period. Now, what are some of the challenges that fetal neurologists face in the counseling? And you saw my first slide is like with the baby doing that thinking pose, because that's exactly how we feel when we are seeing some of these patients every time. Because one is the limitations in the prenatal imaging. You are early in pregnancy, the brain is not fully matured, the baby is really moving, so there's motion artifact. And fetal MRIs by themselves are less accurate and as compared to neonatal MRIs, because you're going through the mom's belly, right? So there's this artifact, there's motion artifact. These are shorter 15-minute, 20-minute MRIs that are rapidly done, and you cannot sedate the baby or to have a better picture. So that's the limitation. There's limitation of the gene panels and other testing that is done. The etiology for any particular condition. So if you look at any brain malformation, be it the missing corpus callosum, be it the cortical malformation, the etiology can be infection, genetic, toxic exposures, hypoxic ischemic insult. So there's multiple factors that can lead to the causes of these CNS disorders in the prenatal period. The brain is immature. There's lack of outcome studies. So when we are counseling these patients, we're doing out on the basis of maybe I've followed 30 children with one particular condition. So that's my limited knowledge. I'll pull up some articles. Most articles will have 20 patients, 15 patients, maybe 100, and very heterogeneous data. And then the pregnancy complications and the obstetric disorders over time can worsen the brain injury. So what you see at 24 weeks doesn't hold true at 40 weeks when the baby is born, because over and above there could be complications that could vary the outcome. And the neurodevelopmental outcomes spectrum for any kind of brain injury or a brain malformation is very variable. So these are some of the challenges we face when we are meeting with these families. And when we are counseling in the field of fetal neurology and meeting with the prospective parents, so what is the kind of imaging required? When was the imaging? What is the best period to be done? What is the infectious or genetic testing? What will be the delivery plan? These are some of the questions that come up in the discussion. Whether a repeat MRI is needed or not, whether a repeat ultrasound follow-up is needed or not, and what will be the postnatal plan? Where will the baby deliver? What kind of care will be required? Will we be requiring a neonatal intensive support? And will a specialist team be required right away? Because that really determines whether the baby can deliver in the community setting or they need a higher level of tertiary care. So it's a lot of collaborative discussion with their referring clinicians and obstetricians to make that plan for the safe transition in the postnatal period. So I'll be touching on some of the commonly seen conditions and from some of the patients I've followed. Obviously, I cannot cover each condition that we see, but look at this and just highlighting some of the themes that I just mentioned. So look at this MRI. So on that first MRI, you see there's mild ventriculomegaly. And there's the ventricles are 10 millimeter is the cutoff, and the mild 10 to 12, 12 to 15 is moderate, more than 15 is severe. And there's some septations there. So there's some septations here. This was a late referral. They came around almost 36 weeks of pregnancy. There was also mild Vermean hypoplasia. This is the postnatal MRI. Again, the Vermean hypoplasia. There was increased mineralization here and mild ventriculomegaly with the septations. So mild ventriculomegaly by itself, if there is no genetic or infectious cause, so if you do the amniocentesis, genetic testing, negative, mild ventriculomegaly can have 90% of the babies will have no problem. But with the caveat that in 5 to 10%, 10 to 15%, there can be a genetic cause, there can be CMV, and that diagnosis can only be completed if you do the amniocentesis with the PCR testing, which at 36 weeks we did not do. We counseled that possibly 90% chance this baby will be okay, but that we are limited in the infectious testing. She's about to deliver in a week or two. And the baby was born with frank CMV. Mild ventriculomegaly, couple septations, was called as query choroid plexus cyst. The baby had frank petechiae, mild hepatomegaly, and had 6 months of Valgan cyclovir. She's now 4+ years, had ataxic gait, was in very intensive therapies, PT, OT, speech, but speaks in sentences, is very advanced in her cognitive development. But whenever you see this white matter being the thinner, some irregular marks, and you see the mineralization that is seen in CMV, she has hyperactivity, learning disability, possibly diagnosis, some social behavioral differences, walking and talking, cognitively learning skills, but we are still monitoring. So that's the kind of challenge you see with mild ventriculomegaly. Now, coming to the other spectrum of ventriculomegaly. So look at this scan. So huge ventricles, right? Like almost getting to 20 on one side, the other side also. This is the postnatal MRI. The baby had huge ventricles, required a shunt in early life. Whole exome was not helpful. The shunt was done in the first month of life, and has some mild motor delay initially, but then really caught up, very advanced in the skills, and has had a single seizure initially with fever, then developed epilepsy at 4.5 years of age. So is on single medication. But look at the huge ventricles, look at the cortex being thinned out, white matter, but the child is still doing very well developmentally. So the prediction of from ventriculomegaly is not just based on size, it's also based on the cause of the ventriculomegaly, whether there are associated malformations, whether there's a cortex is abnormal or not, and whether there's progression in pregnancy. And then at the birth also, the sooner attention, having a timely shunt, connecting with early intervention, all that is helpful. Now, this is another example of severe ventriculomegaly with the good outcome. This was a twin pregnancy and aqueductal stenosis. All genetic and infectious testing was negative. And this baby was followed with follow-up MRIs with visits with neurology and neurosurgery. Finally, there was enough growth and flow there that the baby did not need any shunting, and had some mild motor delay mainly, and is working on with early intervention and continuing to make gains. But obviously, language and cognitive outcome, again, needs to be monitored whenever there is pressure on the white matter, and thinning could be there with this degree of distension of ventriculomegaly. Now, looking at some other cases of severe aqueductal stenosis, right? So this is, again, two different patients, again, the prenatal MRI and the postnatal MRI. Both the scans looked same. Whenever you see aqueductal stenosis with a male fetus, we always bring in the question of the L1-CAM, the cellular adhesion molecule gene testing. So both these babies had that diagnosis. One had a long stay in the neonatal intensive care and then went home, possibly had an arrest and passed away. This second baby, the family opted for comfort care approach after counseling about adverse neurodevelopmental outcomes, and cognitive delay, language delay. These are usually profoundly delayed patients who may be nonverbal and may not talk and interact much with the environment. So this family happened to deliver at a outside NICU, got admitted there, and then got transferred, and then the family changed their decision making, and they wanted to support the baby with the life support measures. So the counseling, what you do at 30 weeks or 36 weeks, may not translate always into the postnatal. It's always a dynamic revisiting the discussion as you continue and as the situation evolves. So also the care for these babies always needs to be based on the region. They may not be an MRI available everywhere. Your counseling may be based on ultrasound. There are regions which may have different outcomes with shunts and different, so these are shunts that were developed in India and then tried in Africa and other countries where they are much cheaper than the shunts that we have, but they found good outcomes and more cost-effective approach for that region where they are able to support those families. So everywhere you go, the care and counseling has to be adapted to the region of the and the availability of the resources. Now, this is more a historic procedure. So when I was an obstetrician in India, we used to have a random case where we knew the baby would be stillbirth and not survive. But this was a recent report, and this was a paper in 2001 from 3 obstetricians from New York and Texas, where they talked about the palliative care approach for tapping the fluid just prior to birth to avoid C-section, to prevent maternal harm, And obviously, these are really ethical discussions which have to be held with the support of the palliative care team, ethics team, and the maternal fetal medicine and the treating doctors. And they talk about how you weigh the risk and benefit of each procedure. So again, the role of the situation, the family's wishes, and it's a shared decision making that is always important for these kind of difficult conversations. Now, the other condition we see, so we talked about ventriculomegaly, mild, moderate, severe, and the likely outcomes. You saw the heterogeneity. The other common consult in the prenatal period is ventricular hemorrhage. So this white here is the fetal MRI, the ventricles. You see the bleeds there. They had progressive ventriculomegaly through the pregnancy, and then postnatally, huge ventricles here. Again, the baby required a shunt. Usually whenever there is post-hemorrhagic hydrocephalus, now whether it is just due to the germinal matrix hemorrhage that you saw some ultrasounds about, or whether it is due to any other causes. So the genetic cause is always tested for. There's this, I know you all were discussing the COL4A gene mutations yesterday. So there is this cerebral small vessel disease panel that we are usually offering prenatally whenever families are opting for amniocentesis with the diagnosis of prenatal intraventricular hemorrhage. And again, this child did developmentally quite well and still young and following. Then looking at similar MRIs and the inherent variability in outcomes, right? So these pictures you see are of two different patients. Again, the intraventricular hemorrhage and the ventriculomegaly in the moderate range. And then you see the postnatal pictures here. Now the child on the left is now 4 years age, walked at 16 months, had some speech and language delay, has a diagnosis of autism, was almost nonverbal till 3 years, but now has several single words, and but does have moderate to severe autism spectrum disorder and did not require a shunt. This one got an early shunt, very similar looking prenatal MRIs, but how the injury evolves and how the white matter around it develops really controls what the outcome is. And then walked at 16 months, normal speech, 1 seizure with fever. Look at the difference in the outcome here with very similar looking pictures. So whenever we are talking to these families, we are always talking about a spectrum, and the uncertainty, you have to always bring it up, and that with time, as the child develops, you will know what the exact outcome will be, but you can only give a range of deficits because sometimes in the discussions, they may get really fixated on they want percentages, right? But like what percentage you will fall in, you don't know. So that discussion is always a very tricky one. Now, collagen mutations, again, look at this spectrum of this huge ventricles, porencephalic cyst. So this started out with the bleed. You see the bleeds here, multifocal bleeds. And then this child is also had the eye findings with the COL4A. They can impact, it's a small vessel disease, the collagen mutations. They can have renal disease. They can have chorioretinal findings. They can also have Raynaud's phenomena. They can have multiple systems can be involved with the collagen mutations. This girl is now 3.5 years old and has cerebral palsy, walks with support, and significant speech language delay, lots of repetitive behaviors, is going to get a diagnosis of autism, and is working with early intervention and making progress on her own trajectory. Now, talking about, neonatal, so many patients who do not get diagnosed prenatally, sometimes you are seeing patients in the clinic, and this was the case I was talking about yesterday. The baby had an initial diagnosis of hypoxic ischemic encephalopathy and also had some hydronephrosis, and they came for a second opinion, and this was the TORM MRI. So you see the degree of injury and thinning of the white matter. There's this huge area of cystic encephalomalacia, or what we call porencephaly, and there's multiple hemorrhages in the cerebellum and scattered. So multifocal hemorrhages, porencephaly with so much of cystic encephalomalacia and ventricles being huge at birth. Will 1 week of HI cause it? 1 week after HI, the MRI will look like this? No. The evolution of such injury takes weeks to months. And so we did COL4A gene testing, and that was positive. And this child was profoundly delayed and passed away at 22 months, also had intractable epilepsy, and we were managing mostly with a palliative approach. So as you are seeing babies being born and they come, when you walk in to see a consult, I mean, this patient just taught me, like, just don't go by the label of what the diagnosis is and try to give a broad spectrum of diagnosis and think what you can do differently or expand your differential. Now, again, the spectrum of COL4A, collagen mutations increasingly being diagnosed. So you see these unifocal hemorrhages, you see this one area of injury in the almost looking like a middle cerebral artery stroke. And so these are the patients who have only a few areas of injury, who do not have recurrent hemorrhages, who are likely to do better with their outcome. So this patient would develop into more like a hemiplegic cerebral palsy with weakness and spasticity on one side. But you can see if there's more worse injury, then the spectrum you saw was with the previous patient, right? This one. But these are some milder areas of collagen mutations, which I've seen in the last few years. Now, this is another patient, very interesting, who was referred for a high AV fistula with a cluster of abnormal vessels on ultrasound. This is the Doppler you see. And then got an MRI, which showed the classic, that bag of worms picture with, this is the postnatal MRI, extensive area of cystic encephalomalacia. So this was thought that there was recurrent bleeds in the prenatal period from this high flow AV malformation that led to this severe injury. And the baby finally, on history taking, there were multiple members with HHT in the family, hereditary hemorrhagic telangiectasia, where they have these very high chance of cerebral AVMs, 10%. And this baby underwent a palliative embolization for the AVM to prevent further hemorrhages in the early period, but is profoundly delayed. And finally, the testing did come positive for the HHT gene. So whenever you see history, AVM in the prenatal period, that's one of the top causes we see with the HHT. Now, the next coming on to the spectrum of midline malformations, right? So whenever on ultrasound, so this is a fetal MRI, but whenever the anatomy scan picks up missing septum pellucidum, that's a sign for doing a fetal MRI to evaluate the prosencephalon. So look for the corpus callosum, look for the septum, look for the optic nerves, look for the midline, look for holoprosencephaly, rule out holoprosencephaly. So those absent septum by itself is not a diagnosis, but it is an indicator to look for other associated malformations. Now this septo-optic dysplasia, so you can see this is the postnatal absent septum. This child also had, this one has the hypopituitary, so requires the stress dose and endocrine is following, but the eye exam was normal. Optic nerves were normal. And septo-optic dysplasia, again, multifactorial, genetic, infectious, 4 genes have been described, but there's a large number of patients who have no causative etiology identified on genetic or infectious testing. Now, so they can again have mild to moderate delays or severe delays. So it's a very heterogeneous outcome. So when you are counseling families after seeing a prenatal septo-optic, prenatal absent septum, you can only call, if you do the amniocentesis with genetic and infectious testing, there is still a 20% risk of septo-optic dysplasia postnatally diagnosis because you are limited in not being able to test for the endocrine malfunction and you're not able to see the eye exam. Just having the optic nerve visualization on the fetal MRIs is very difficult. And even if it is commented as seen okay, but you are early in pregnancy, you need the full eye exam. So that counseling process involves the risk of septo-optic dysplasia. Again, that's a small series of studies. But the spectrum, so this child is almost 4 years old. He's advanced in his cognitive skills. He had no motor issues. He's advanced in his cognitive skills, but has lots of features and got a diagnosis of autism spectrum disorder. So communication, functional communication, social interaction, but he's reading and writing at grade 1 level when he's 3.5. He's like a savant. Like, he's a patient, I keep staring at him I don't know how, like, every time I say, like, with these children, how they amaze us. And I tell his parents, oh, well, when he goes on TV, don't forget to invite me. Like, he will someday end up in some show doing something. But that's how he's doing. But he has autism. He doesn't look at you. He comes with a slate in the class, and he keeps writing on it with the chalk, and anything I speak, he writes the full sentence at 3.5 years. So we keep staring with open mouths, like, oh, what's going on? Okay, but we are happy, and family is happy. This is their only child, and it was a very difficult pregnancy. And so the counseling, really, you have to empower the parents to support the children and also give them a lot of hope. The other diagnosis we see in the midline is agenesis of corpus callosum. Again, it's a very wide spectrum. So you can see here the connection is missing. You see parallel orientation of ventricles and what we call the stag horn, deer horn orientation with the missing corpus callosum. This is a functional MRI study. Again, the spectrum with these children is really variable. And researchers are really trying to look at the comparison of structural and functional imaging. With DTI and functional scans, they found that the subcortical networks are actually increased in children who are missing the corpus callosum. So the physical connection is missing, but the brain is reorganizing itself to achieve typical connective networks. And that's how some of these children are doing really well. But they still struggle with executive functioning, complex tasks, social interaction, behaviors, and all these mild learning disability, attention deficit hyperactivity disorder. So these are some of the milder symptoms. But agenesis of corpus callosum, when it is associated with other brain malformations, say a cortical malformation or a genetic or syndromic diagnosis, some which have been identified with the female Aicardi syndrome and others, and some with the male fetus. So those are more the profound delay with seizures and more like the moderate to severe cerebral palsy-like phenotype. So this study was done in Australia. And it points to make us all think, like, are we looking at the correct outcomes, right? We are looking at these Bailey scales, the developmental scales at the pediatrician and neurology visits. We're looking what's their language score, what's their motor score, and trying to give the family those numbers and with the outcome. But what are they functionally doing, right? How are they being integrated in school, in the community? So this study actually looked at individuals in Australia. They did 8 face-to-face qualitative interviews. They were age ranges 23 to 72 years. So these were adults who had lived their whole life with corpus callosum disorders. They had missing or dysgenetic corpus callosum. And they found these key issues, and they gave a map for the policymakers to think of what are the problems, right? Like, because these are individuals who are walking and talking, but they have a hidden disability which we are not able to see. They're getting some IEP, individualized education plan, some rehab, some support in school, but they are struggling with inclusion in the community, with inclusion into the educational system, transitioning into employment. So they're not successfully maintaining employment. And their reaction to their diagnosis with time, like how they are perceived by their family, by their peers, by their siblings, by the treating physicians. So all these are important things to consider as you are following these individuals across their lifespan. And very important to collaborate with the adult care people who may be clinicians who are not very knowledgeable about these congenital disorders or early origin neurological disorders. Now the limitations, right? Again, I talk about limitations in the prenatal MRI. So this is a patient I saw early on in around 24 weeks, had a missing corpus callosum, agenesis of corpus callosum. On ultrasound, so usually whenever there is agenesis of corpus callosum, we also have colpocephaly, or what we call enlarged ventricles. That by itself is not a separate finding. This is the ventricles which just expand. And they usually are followed by serial ultrasound during pregnancy. This patient had progressive dilation of the ventricles throughout the pregnancy. And the postnatal scan, double cortex. So subcortical band heterotopia, that was not visible in this prenatal MRI. We counseled based on agenesis of corpus callosum. And the baby actually had subcortical band heterotopia, which is due to the DCX gene, double cortin. This is usually a question on the boards on the neurology. And they usually have seizures, intellectual disability, behavioral issues. And so this is a limitation in early fetal MRI, where the cortical maturation and layering has not happened, so this could only be diagnosed later, right? So that's something you have to always consider, the limitation of prenatal scan, and mention it in all your counseling. Now, shared decision-making and the role of palliative care. So there's a couple recent reviews on palliative care, which I think all in neurology should read. Even neonatology, neurology, pediatricians, when you are talking and making decisions with these families in early neonatal life. Now, this patient was, so huge ventricles. There's this cerebellar hypoplasia. There's this kinked, thin hypoplastic brainstem. And this is the postnatal scan, very smooth brain, lissencephaly. Initial diagnosis was possibly whenever you see a Z-shaped kinked brainstem with hydrocephalus, that's one of your top diagnoses. This child actually had a tubulinopathy, and tubulinopathies can also look like this. So those are your big differential, the tubulin mutations and Walker-Warburg. And now the family in the prenatal consult opted for comfort care approach. They said, we will not do anything. We want to maximize time at home, and we want to take the baby home as soon as possible, so we don't want any drastic measures that delay our discharge. When the baby was born, the baby was having apneas. So obviously neurology jumps in right away, connects them to EEG, and those were seizures. And then we told the family, and they said, yes, treat. We want to manage this. And the baby was in status, actually. And that's one of the few. Usually they don't seize till few months, but this is one of the few. And the other collagen mutation that I showed you, who's 3.5 years, she had seizures at birth. So some of these brain conditions, they will present with seizures at birth. And so we escalated to treatments through the status pathway, went up till midazolam infusion, and midaz infusion. And after that, after 24 hours, we regrouped. And we told the family, like, this is not showing any signs of improvement. The seizures are not responding to any medication. This is a chronic or neonatal onset epilepsy. And we're going to escalate Topamax and do more like a chronic management and try to take off these, because the baby ended up being intubated now because you are on midaz infusion. And the family's one biggest desire was to go home, but they wanted treatment of status. So we were trying to weigh in everything. So we took off the infusions, we started the Topamax, the tubulinopathy exome came back in the first week of life. Again, several family meetings, how to get the baby ready to go home, and then finally went home after 2 weeks on a feeding tube with support for with Topamax, with support for a possible Ativan with hospice involvement and support at home. So the family thought they had few weeks with the baby, but the baby is now almost 2 years on 4 medications, profoundly delayed, requiring feeding support, some oxygen support. So the decision-making that happened prenatally did not translate into the postnatal decision-making. At every step, there was a difficult conversation and family meeting to redirect the goals and then try to achieve those goals in collaboration with the family. So the palliative approach, having your palliative teams get involved early on, really helps them, and even meet with the families prenatally really helps to support them through this difficult process. And neurology, of course, is your being with the family, start when you get to know them and then meet them postnatally. That also helps ease some of this difficult transition in the journey. Some other common conditions, again, posterior fossa malformations, so Dandy Walker, majority will have significant moderate to severe developmental delay. You see the vermis and cerebellum is all gone. They need shunt, hydrocephalus. Many will get a genetic diagnosis. Some will also have diagnosis of autism, will be very common with these posterior fossa malformations, and then seizures. Now, complex decision-making, always the other complexity, what happens if parents have a disagreement? So this was the most complex patient who I've seen in the last couple years, who underwent 3 MRIs. They got a prenatal exome. The problem here was the cerebellum, right? So we were talking cerebellum can cause motor issues, but also can cause speech, language, and autism-like features. And there was some hemosiderin on one side, so it was thought to be a encephaloclastic, like a injury secondary to a cerebellar hemorrhage. The repeat MRI, again, showed that there was some hemosiderin on the opposite side, but that cerebellum was preserved. So the family opted for repeat MRIs because they said that it might change their decision-making through pregnancy. But the main reason was that they were split in their decision, right? They could not get one person wanted to continue, the other did not want to continue the pregnancy. We also have a team of perinatal psychologists who get involved in such patients, and we do joint consults with the MFM, neurology, then the psychologists meet with them separately. And the whole exome really inconclusive doesn't help us because the injury is there and the bleed is there, and we don't know if the bleed will happen again and injure the opposite side also. And so really what is the outcome for this family that we are looking for? Like the child is now 1 year old and they've only seen me once, so I believe he's doing okay. But really the outcome here for me in my mind was like, I hope these parents stay together. Because throughout the pregnancy, that was the best outcome I was hoping for, because they also had an older child who had severe hypotonia and delay, and so we got genetics involved to see if there's anything that ties it into this. So there was a lot of complexity in this pregnancy. So this is some of our model through the early prenatal period, and in the outpatient clinics have support with achieving universal screening. We are trying to get universal mental health screening for parents in the prenatal period, and also trying to expand it to the NICU and to the outside outpatient clinics. Now, coming through, so you can see the challenges, and so trying to meet all these challenges alone is a very difficult path. So in the pandemic, I had the opportunity to apply for this AAN leadership program. And through that, I emailed a group of fetal neurologists across the country and asking them, like, can we build a consortium? And each of them, and I was hesitating to send that email, and I'm like, oh no, people think, what am I trying to do? But each of them said, oh, we've exactly been thinking about this. We struggle so much every day with these families and these diagnoses and the way the field is changing. So we set out to, the first study we did through the consortium. So they're all spread out throughout, and so we are a group of 8. And this was the survey that we did to understand the fetal neurology practice. This is the dots represent the responding institutions. So what is the question was, what is the earliest gestational age do you do the MRI for? And you see the variability of what is happening across the country. In one single country, there is so much variability. So imagine what's happening around the world, we don't even know. So this is exactly why this collaborative networks are really important to advance newer fields where we don't have guidelines. Then what are the most important consult diagnoses? So these are some of the common: ventriculomegaly, midline absent septum, agenesis, holoprosencephaly, cortical malformations, posterior fossa, microcephaly. Now, but there's also a role to get involved as the field expands. Cardiac babies, right? They all have prenatal hemorrhages, white matter injury, congenital diaphragmatic hernia, growth restriction, other systemic illnesses. So this is where the field will expand gradually. Neurology getting involved in other conditions which can cause brain injury and not just the primary neurodiagnosis. Now, trainees and education, right? So genetic counselor involvement, again, region-based, very, very variable. Many will involve, some will sometime. Trainee involvement is really low. I know Dr. Means was really proactive in following me every minute, every day, and stalking my schedule and coming and learning. But this is a field, I think, whether you are going to do fetal neonatal neurology or not, this is coming at you. Wherever you go, you get hired as an attending anywhere. I've had so many fellows text me, and they did epilepsy, and they went to another institution with their first job, and in their first week, they had to see a fetal consult, and they were texting, what should I do? Well, so this is a field which is going to come every institution you go. MRI is so available now, and they're going to ask you to do these consults. So as much as you can learn, and this also gives you a perspective of where all the child neurology starts. Be a genetic disorder, be a brain malformation or a metabolic or anything, these are the children you are following across as they grow older, whether it's epilepsy or they have developmental delay. So you really need to pay attention to this early period. Prenatal genetic testing, again, was very variable. Exome, insurance barriers, what is available, what is not available, how much does the family want to know. So you're seeing the heterogeneity in the practice, the heterogeneity in the postnatal care, right? So not everybody is doing the ages and stages questionnaire. Majority are doing the developmental interview. And formal developmental testing is really less of, it's not easy to get at formal developmental testing based on the resources and the teams that we have. They also, all the responders mentioned like really big, everybody wanted guidelines. And that was the big theme at the Fetal Neurology Special Interest Group with the Child Neurology Society. So if you are interested, please join that special interest group. So there's big push on the guidelines. Everybody wants to talk more about how we can have collaborative registry for outcomes and all these education topics. So we've done some of the work to advance the education in the national conferences. Now, globally, the congenital disorders are really taking big importance because as the care for premature infants and other conditions is improving, what is coming to the surface is the morbidity and mortality related to congenital disorders, right? So, and that is a big area to prioritize care for women and children and early origin disorders. And you can see like 1 in every 33 babies in the United States itself are born with the birth defects. And it's the leading cause of infant deaths and accounting for about 20% of all infant deaths. There was some recent news article about rising infant mortality due to these disorders. And so these were the themes given by the World Health Assembly: strengthening surveillance system, capacity building, and for the care of congenital disorders, raising awareness for newborn screening programs, supporting families in their stressful journey. This is not easy. And then strengthening research and collaborations to advance the field. So this is some like a roadmap. So mostly like single center studies, multi-center grants. If you can have collaborative large-scale outcome studies, that would be the ideal. And then really fetal neurology is very much a moving target. Interdisciplinary collaborations are very important. Collaborations with families are important, and we are currently trying to do a survey, sending to parents. We are trying to understand their perspectives on outcomes, what are important to them. And then in collaboration with maternal fetal medicine, newborn brain, Child Neurology Society, geneticists, this is a field that really needs lots of interdisciplinary collaboration. And then developing the best practices. This is a picture from some of us in the seminars that we did. In the seminar we did at the Child Neurology Society, the main theme was prognostic and diagnostic dilemmas in fetal neurology. And there was such an interactive discussion from the audience. And then we've expanded some collaboration globally, Italy, UK, Dr. Tony Hart and Bridget Walmer and Barbara Skelsa. And then from India, my ex-MFM colleague, Dr. Dadwal. So we've really started working on practical guidelines and recommendations. So all the 8 in the consortium, along with these global authors, this is our first paper that came out, and all other diagnoses will come out gradually one by one. So if you are going to see a patient with fetal ventriculomegaly, we've tried to come up with a consensus, non-Delphi, non-uniform, but like expert consensus-based guidelines for pediatric neurologists to manage these patients. So this is the first of the papers, and I think I uploaded it in the CME portal of the conference. And then for those interested, the volume 1 of the seminars in fetal neonatal medicine in May 2024 this year was out, really highlighting the unique touch point that this discipline has and the interdisciplinary training and care required for successful outcome for these families. And really, as child neurologists and fetal neonatal neurologists, we are in a unique position to interface with all these specialties to make an impact early on that can really help with the disability and outcome and morbidity and mortality across their lifespan for these early disorders. And this is also a big part of the agenda on the American Academy of Neurology Brain Health Summit, and they've started a group which has a conference every year, and then they collaborated with the World Federation of Neurology and all the European and other societies. And this early arm is really important here. Start with a strong foundation, and why care in the early fetal neonatal period is really important for the brain health across lifespan and how to optimize the outcomes. So this is early origin neurological disorders are really important in child neurology. Now, so the field of fetal neurology is really complex, and obviously there's a lot of uncertainty. And while we give a lot of information to families, we don't have all the answers of what this will translate into, what their child is going to do at 5 years, 10 years, or 15 years, right? So the one other thing you have to really take into consideration is addressing parental guilt. Especially when you're talking to them, mention that nothing that you did or did not do that led to this, right? Like, so the moms especially will internalize their thoughts, and many of these families, the patients are just crying throughout the whole visit. So I always follow up and call in the next week or so, and just make sure they are doing okay. The team of perinatal social work, perinatal nurse, mental health support, all this is very important in fetal neurology. You're giving so much information, but you're showing so much uncertainty, but acknowledge that. Then also give them hope and empower them, because if they don't have hope and they don't work with the child, the outcome is really dependent on the environment a child is going to get. Now, these are 2 children, so we had a runway, like a fashion show at CHOP for fundraising. These are 2, so this one, Alex, he has agenesis of corpus callosum. So his mom is a dietitian, and she came crying. She had been counseled for termination, but she heard the whole spectrum. She was only, when she came to us, she was counseled. So the postnatal knowledge of following these children over time is really important, because the obstetricians and maternal fetal medicine specialists, they do amazing counseling, but they don't see these children grow up. But we see some of the good outcomes, the not so good outcomes, and the more severe outcomes. So that knowledge the family needs to hear, and then they can make their decision what they want to do. So they continued the pregnancy. This child, he speaks 3 languages. He's very hyperactive. He also got a recent autism evaluation at 5 years age, just because the parents were so worried about his being hyperactive. There's like, we want all evaluations. He did not have an autism diagnosis. He's only having behavioral issues at home, but he's amazing in the school and community setting. So that's a different issue, and we're all working with him with guidance and the behavioral counsel. But this guy, he speaks 3 languages, and he's like obsessed with cars, but he's amazing. Really, and then this other one, he actually, Dr. Means, actually you took care of him. And he was born, he was on ECMO. So he's not a fetal diagnosis, but this was an unexplained neonatal encephalopathy. Absolutely normal pregnancy. The baby came out, had PPHN, went on ECMO, had respiratory failure, and he was on ECMO for many days. He had some strokes, some multifocal hemorrhages, and he spent about 5 months in the neonatal intensive care, and went home on a feeding tube that was weaned at 1 year of age. And he also speaks 3 languages. And at age 3, he knew that if his grandma, who speaks Mandarin, he would talk in Mandarin with her, and the other grandma, who spoke the Indian Punjabi language, he would talk in Punjabi with her. Mom's Chinese, dad is Indian. They would be competing in teaching him the language. And I always tell parents, like, speak all the languages you want with him, and with the child, because the more they hear the language, this is their time to, and he's so smart. But they are both obsessed with cars. So I connected both of them, and now they are best friends. So they live near each other somehow. So they said, like, oh, they met at the runway, and they said, oh, can you share the address? I want to go and meet her. I'm like, oh, well, I'm not allowed to do it. But then I asked the social work, like, please do whatever you can to connect these families within the rules. So that's what is the theme with these families: hope and empower them. Because they are going with home with a child, they know all the adversity. There's no need to hammer them at every visit with every negative that you see in the child. Talk about the positives. If I tell them there's 60% risk of seizures, I always say 40% don't have seizures. So you have to weigh the positive and negative. Now this is a very nice picture, and it applies to any other child with a brain injury or brain condition. So my son, I shared in the pediatric grand rounds, he has cerebral palsy. So one day when my nanny, who drives him for his computer access technology class, she didn't come, so I drove him for that class, and I never knew all his instructors were visually impaired. So they were walking like this or with sticks, but they were training him in that computer class. And they had this picture on the wall. The only way to discover the limits of possible is to go beyond them into the impossible. And it applies to each of our patients, right? Unless you go to the next step to try something, you don't know, if you have not tried, you don't know whether they can do it or not. So just pushing them to their best maximum potential. And so I thought that picture was really cool. And that's it. This is just a picture of all the places that I've been. That's my school in India. This is my medical school in India, Banaras Hindu University in the holy city of Banaras, where I also trained to be an OB. This is where I did my MFM fellowship, and I was an attending. Then I trained at Texas Children's, and my journey into child neurology was like destined. I did not choose it. The field chose me, and so I'm ever grateful to Dr. Tim Lodsey, Dr. Clark at Baylor Texas Children's, who mentored me into fetal neonatal neurology, where I could use my MFM experience, and currently at CHOP. Yeah. That's all.